Hi, everyone. I'm Kelly Mafia. I'm a behavioral health director with a federally qualified health center in Huntingdon County, Pennsylvania. And I'll just mention, I joined the call today because we are getting ready to start telepsychiatry services in our system. And so I am definitely curious about learning a lot more about the psychiatric collaborative care piece of integrated behavioral health.
Great. If you're just joining, we're kind of going around introducing ourselves. And if you don't mind putting your name in the chat and your role and your organization. Dr. Blackman, I see that you just logged in. Welcome.
Thank you. I'm Karen Blackman. I currently do collaborative care for 2 large clinics at Sparrow Hospital in Lansing, Michigan that include family medicine resident training, which I've done for a long time. And I am retired from the family medicine department at Michigan State University. But I'm a psychiatrist. So.
Great. Welcome.
Thank you. Hi, Dr. Beecroft.
Hi, Karen. How are you?
Good, thanks. How you doing?
Good. We're only getting a little bit of snow today.
Right.
Well, we'll go ahead and get started. I'm Dr. Patty Gibson, and I'm a psychiatrist in Little Rock, Arkansas, and have been doing behavioral health integration in different roles in the VA, in a private system, and now working with a nonprofit called Arkansas Behavioral Health Integration Network. I was volunteered or happy to be a co-chair for the Collaborative Family Healthcare Association Psychiatric Special Interest Group. We're a new group. We've done a couple of presentations at the national meeting, Mark Williams and Lori Rainey, Tom Salter and I, and so we're looking forward for CFHA to be a place for connection of relationships of various psychiatric providers around the country, but also a place that we can connect with people of all disciplines, clinicians, administrators, and to continue to learn from each other, but very much about building relationships and finding a way to serve the larger community and CFHA. And today, Dr. William Beecroft, I appreciate him being willing to speak with us. And some of you know him, but I'll do a brief introduction and then let him add to it. But he is currently the medical director of behavioral health in the Blue Cross Blue Shield of Michigan Healthcare. And we'll let him explain his role a little bit in that, but as part of strategy and planning and addressing payment issues and referral strategies and some of the initiatives there. He's been working to get reimbursement strategies instituted for the Blue Cross Blue Shield of Michigan population, having to deal with individuals with first psychotic break, and has been instrumental in being a strong advocate for the collaborative care model and getting an information source for people who are first adopters of the model in behavioral health care, case management and delivery. Also working to develop payment models and institution of psychiatric observation units, crisis residential units, and mobile crisis units. And then during the COVID crisis has been able to facilitate outpatient substance use disorder treatment protocols to help avoid inpatient services and being a liaison with providers and Blue Cross Blue Shield of Michigan. He is a physician, graduated from Michigan State University and did training in internal medicine and then psychiatry. And in psychiatry has had experience and training in geriatrics and psychosomatic medicine. So he is has been a practicing psychiatrist doing inpatient consultation liaison and community mental health, and been the chair of a department of psychiatry at the Ingham Medical Center in Greater Lansing. And so he brings experience in the field doing psychiatry as well as doing integrated care. and working within a payer and an administrative role. So we've met with him and shared some of his successes and challenges and ways that they've been able to do some problem solving in Michigan. And so we appreciate you coming, Dr. Beecroft, and sharing with us today. So I'm gonna turn it over to you and let you guide us. You did send us an agenda, which we sent out in the email. But Dr. Beecroft, I'll let you go ahead and from here. Thank you very much. And
Yeah,
if
thank you for that.
anybody's
ahead.
still joining, if you will put in your chat, your name, your role, and your organization. And if you have any specific questions as we go, please feel free to type them in there. All right, Dr. Beecroft.
Yeah, thank you for that generous introduction and for the time today to be able to talk about this. I wanted to not so much give you a presentation, but really help to kind of engender some discussion about this. And we have some experts on the line actually right now from the Ames Center, which would be additionally helpful for us about collaborative care. But as was mentioned, I've been doing, in essence, collaborative care my whole career. As a consultation psychiatrist, when you're making rounds in the hospital, you get the family practice docs or the cardiologists or the internists kind of take you over to a corner and say, hey, I got this patient coming in this afternoon. What would you do? And about a month later, they come back and they say, well, I did what you asked me to do and they're doing a little bit better, but what would you do now? So I've been doing this stuff for all my career. And when it came out that I took the job at Blue Cross 8 years ago, was really trying to incorporate and really push the integrative model at that time called integrative model, and now collaborative care being a component or a portion or a version of integration that really is now being able to be paid for much more effectively. And in Michigan, we've got several practitioners that have really very sophisticated integrative models, primarily using a co-located service, which was how it was done early on. And with collaborative care, that's only been able to be expanded, I think, even more. So that's good. But in the agenda that I put out, I wanted to open it up to begin with. Is there particular questions that people have to start with? What would be the focus that you'd really like to see? And if we don't get any questions early, kind of dive into the agenda. We can ask questions at the end, but I'll use my best psychotherapy skill and just be quiet for a minute and let people type in the chat of what their questions might be, or just raise a hand and jump in and ask.
There's been a question about what's the status in Michigan and nationally of the collaborative care copay. That's one question that we've got. Okay,
well, that's good to lead off with. And if other people have them, you can send them in. But okay, well, back in 2017, when CMS mandated collaborative care codes to be paid, there was very little in the way of guidance from CMS as to how to configure the codes, how to be able to work with them. It was clear that they wanted a copay. And so with that, we did go ahead and configure the codes. We have a very complex system, as most payers do. And almost soon thereafter, within 2 or 3 months, we started having our early adopters try to build the codes as we configured them, and found that there was significant configuration issues. So that became a hobbling factor for us. The other thing that was found, we did spread this out to our commercial product and in both the HMO and the PPO that same year. So with that, we did find that people had identified a barrier of the copay being substantial. That the first time patients got a second copay for the month and they hadn't, in quotes, seen somebody, they were very upset, dropped out of the program. And so that really started us along a path of looking at figuring out how to get rid of the copay, the co-insurance, how to be able to configure the codes correctly so they would pay and pay easily, and then be able to help encourage our not only early adopter providers, which we had about 30 in the state, to be able to expand that network even further. And simultaneously, what happened is our senior administration did an analysis of our population, and they found really two poignant pieces of information. One was that 24% of our population had a concomitant behavioral health issue. And of that 24%, they consumed 57% of our overall spend. Another one that was 13% of patients had a behavioral health issue, consumed about 25% of our overall medical spend. So very, very similar. And that got their attention. They started looking at, okay, how can we address these members that have a behavioral health condition in a way that we can get them well and move on? And that's where the work that we had done early on collaborative care, being able to circulate the literature, circulate the, I believe it was the Congressional Budget Office that back in 2010-ish or so, 2012, put out a document saying that with Medicare alone, there could be savings of roughly $600 billion if the collaborative care was utilized. And that eventually led to 2017, the mandate. But our senior administration got a hold of that information and started saying, well, what do you think? Shouldn't we make this something more important for us and adopt this and expand this? Which I fully agreed with at the time and was able to support. And so really two things happened at that time, not only being able to socialize that information to senior administration and to be able to make the case that, that if you treat the behavioral health issues, the medical issues have a chance of being able to be under better control. Consequently, if they're under better control, they're not going to the ER, they're not going to the hospital, they're not spending inordinate amounts of money on their medical needs. And the literature supporting over 3 years, you get a closer approximation to a normal overall medical spend for that individual, as would be a healthy person in the population at that same age match. So we put together what's called a project in our system to be able to configure the codes correctly, to be able to eliminate the copay co-insurance. That led to a legal interpretation with our legal advisors as to, does this fit preventive health care? Does this fit any safe harbor for our high deductible plans? And really went through all of that analysis. After a year and a half, we're able to get those things all put together and then launch the collaborative care revised billing guidelines to be able to help our providers understand this a bit better. And simultaneously, we have a practice transformation portion of our company that does a program called PGIP, which is Provider Group Incentive Program. And with that, they were able to dedicate for late this year significant funds to be able to fund not only an education program for practices with University of Michigan, and the other group was what I call a think tank, but a group of transformation for medical clinical practice called MIXI on the west side of Michigan. And with these two vendors, we're able to put together an educational program for our providers. We were able to pay the providers to take the time off work to close their practice for a period of time. We were also able to pay an incentive for them to adopt this model and an incentive for them to continue this model ongoing. So with that, we were able to enlist 54 practices this year that have gone through the training. Those 54 practices represent approximately 400 physicians or providers. could be nurse practitioners and PAs in the practice also that were trained in this regard. This has worked out pretty well. We have a plan to be able to do, initially we were going to do 125 next year and in 2022. With COVID and the concern that there's going to be a rush towards getting our general medical care taken care of and our doctors are going to be pretty busy, we've backed that off to 75 practices for next year and ideally 125 in 22. And if we can expand that to 23 with 50 more practices, that would be ideal. We don't require that practices have to go through the training. They could right now be able to build collaborative care codes as long as they fit the definition of the codes themselves. They've done their own training. But we really encourage them to go through this and to be able to have fidelity to the model of collaborative care. We've also been asked, well, does that mean that you can't have a co-located practice? No, you could also have a co-located practice. The difficulty with a co-located practice is the providers get filled up as they would in a standalone bricks and mortar practice. And so there's still an off-putting aspect to that. When I say off-putting is you take a patient in, you start working with them, you treat them for a period of time, and some people stay long-term, but if you do that, you don't have room for a new patient on the other end. So you have to figure out a way of being able to transfer their care either to stability that they don't need treatment or to be able to transfer them to another provider somewhere else outside the practice. So it can still work in both ways. So it's been actually quite a journey to be able to get it to the point that people can get on board. You can get plans to be able to do this. You can show them that there's a significant benefit to the population, that there's a significant benefit to the providers, because we do know that primary care providers that get into this model find it very satisfying. They have less burnout. When I go to the regional medical directors meetings, most of the primary care providers are telling me that their statistics are 75 to 85% of primary care is burned out doing medicine the way it usually is. We also know in the psychiatric world, from our journals that we have, the literature from our association, that psychiatrists are burning out also and leaving medicine altogether. So this model tends to be able to rejuvenate people. They tend to feel much better. Psychiatrists tend to have been trained how to work in team practices and in general like that. So that really keeps people interested, and it increases access to psychiatric services, because when a patient comes in and the primary care doctor identifies that they have a need for psychiatric services or behavioral health services, either through the screening process, which is a component of the collaborative care, and being able to assess their patients in their practice, now they have access to that, and they have a sense of backup that they're not doing this stuff on their own and having to keep up to date with psychiatric services along with GI, cardiology, endocrinology, immunology, all these other services that the primary care space has to take care of all by themselves. Now they've got a consultant to be able to do that, and they can integrate that patient into the behavioral health space by that relationship they've had with them previously. So it really works for the patients to eliminate the stigma. It works for the primary care doctors to be able to have that backup and be able to learn behavioral health current treatment technologies and interventions. And for the psychiatrist, it's rewarding in the sense that they get to use the academic skills that they've learned and the tricks that they've learned over a period of time to be able to help people get better. And there's a lot of art to all of medicine, and to be able to share that with another provider of care, that really becomes very energizing. So I think it suits a lot of needs for a lot of people in doing those kinds of things. I'm kind of following my outline here a little bit, but getting through it pretty quickly. We talked about the expansion, the incentivization that we've had. What we're expecting as outcomes is what the literature would support. And it really depends on the fidelity of how the program is really followed to be able to see the best outcome. But we do know that after a period of the first year, you're not going to see much in the way of change in the spend. People might start to get better from the behavioral health side. We have one early adopter that has given me some information that when they were treating depressed patients in a treatment as usual standard format, their time frame was in the average between 50 and 80 weeks to be able to get a person with major depression into remission. And now that they've had the collaborative care process going since about 2015, their average is now 16 weeks, which is very similar to the best outcomes we could have in the STAR-D trials of really good quality care for depressive disorder. So that in itself is really energizing, that people can get their behavioral health issues under much better control quicker than they used to. And then consequently, if they have, say, diabetes or heart disease or hypertension, they can pay more attention to the things that they need to do to treat that they can go to pulmonary rehab, or they could go to their diabetic classes. They could do the exercise that they need to do, eat the right foods, prepare the right foods, maintain their medications, these sorts of things much more effectively in this process. In year 2, you may start to see some movement in that overall spend. It actually probably is the quickest slope change in the progress of getting back to a more normal population. And then by year 3, you're going to see some plateauing by the end of the year of where that spend is going to end up, but also where the patient's at that point, that they're reaching their best quality of life and best healthcare outcomes at that point in time. And then to continue that on an ongoing basis, because we're treating chronic illnesses in the behavioral health space. Depression's in essence a chronic illness. Anxiety disorders are chronic illness. Episodic worsening, but it is a chronic illness. You have to keep track of it and keep on top of it. As are diabetes, heart disease, hypertension, COPD, all of these other things. So using those same kind of thinking processes of treating this as a person with multiple chronic illnesses, that's going to be your best strategy to really take care of them on a long-term basis. I burned through a lot of things pretty quickly. I guess why don't we open it up to any questions or discussion, what other people have seen, possibly some ideas from the Ames Center folks about how they've seen this start to grow. I'm seeing in other Blues plans around the country that there's a big interest in this, and that there's a move in Blues plans to facilitate collaborative care. I'm not aware of any that have done the educational programs that we have, but I know that they're working through the payment schemes to be able to make it billable and practicable by practices. So with that, I'll be quiet for a bit.
I just wanted to get a point of clarification. Is there still a copay or not?
With Blue Cross Blue Shield, through all of our products, there is no copay, no co-insurance for collaborative care.
Okay, is that unusual?
That is extremely unusual.
Okay. Around the country, that when people bill, they will normally for collaborative care have a copay.
That's correct.
Okay, thank you.
Bill, I do think that the Henry Ford Alliance, I think their behavioral health specialists have gone through the education component, or at least part of it.
Yes, they have. Yep, they have. We've had some of, as I say, 54 education of our provider organizations have gone through this. Henry Ford was one of our first ones that has done this. University of Michigan is one of the trainers, and they have a big collaborative care process ongoing now.
Oh, that's good. That's so good. Oh.
Yeah, Friday.
Bill, hi, Mark Williams. We met before. Nice to see you again.
I've been involved in some of those trainings that you're talking about, so it's a fun project. I really admire what you're doing. For our group here, I wonder if you might say a couple words about the culture of the payer and how it might be different than what we're used to in our practices and in our own areas, how to form alliances with a payer.
Well, Blue Cross has come a long, long ways, Blue Cross of Michigan, from where it was when I came on board. It probably stems from the fact that my predecessor was also a psychiatrist who's now a vice president of senior health services. We've gotten a lot more attention as to the psychiatric needs of our membership. One of the things that really made it apparent was when the ACA came in and we had a large influx of exchange patients. In our HMO, we were the biggest exchange payer the first year, and I think that lasted for 2 or 3 years into that. And with that, you know that the exchange patients, many of them were members that had received services from community mental health previously, that were on Medicaid, but pushed out of Medicaid by the exchange program being available to them, especially the silver plan that allowed them to have subsidies and essentially free insurance. So with that, we inherited a relatively huge number of patients with chronic mental illness and many with chronic and persistent mental illness. Our providers had really never been exposed to that. They were used to, I hate to call this, it's not meant to be pejorative, but the garden variety person with depression and anxiety disorders and adjustment disorders and more, in quotes, routine, but still important mental illness issues. But they weren't used to that. They weren't used to dealing with people with schizophrenia, schizoaffective disorder, bipolar illness. So consequently, we saw the negative consequences of that, of the revolving door. We had lots of readmissions. We had lots of people failing. And so we had to really get a hold of this pretty quickly. And we started looking at how we can do this. We came up with some ideas, socialized that, and by doing that, became really visible to the higher administration of our company because we had some significant successes with those programs. And insurance companies are just like any other business. They're looking at the bottom line and what you do with money, but they also look at the outcomes. They're looking at their HEDIS measures, the quality outcomes. The accreditation agencies kind of look over your shoulder and are looking at what are you doing to be able to affect the quality of care for your patients. And all of those things showed positivity. And again, that made us more valuable. So when we came up with this idea of taking a mandated service, which is a good mandated service, but it really helped us to move ahead, and expanding that to our overall population because of the potential benefit. And then serendipitously, this big study of finding the behavioral health penetration and cost of those members that had behavioral health issues, that really made it valid for them to be able to then listen to me, Dr. DeFranco, the other people that were supporting us in the administration, Dr. Simmer and Dr. Kashishian, all senior vice presidents of the organization. That started to add a crescendo that then behavioral health became important. It became necessary to address. And we started getting seen, I guess is the best way of describing it. And we've continued that direction that our chief executive, our president at this point, really values the behavioral health aspects of people's care and recognizes the holistic aspect of really caring for people. Ultimately, as a business person, it's to save money, to be most effective and to use the money that we get the most fiduciary way, to keep it. I always say it's the 5 wins. You know, the patient wins clearly because they're feeling better, they're doing better. Patient's family wins because they get a significant person of their family back into their world. The physicians, the practitioners, the therapists, the other providers, nursing staff that help to see this person get better, they win too because they've done their professional fiduciary responsibility. And that's what we went into this business for, is to help people. Our plan wins because we can be able to keep our prices lower. We can be able to use the money most effectively, and the people can buy our insurance win because now they've got a pretty effective product that they can get their whole healthcare taken care of. So it really became a package for us. And it just kind of synced. But that's important for other places to be able to see that too, that the things that make a difference at the business table is finances, but also the outcomes for patients. And if you can show that one plan did it, and we're a pretty large plan, we've got 7 million people that we cover as far as an insurer. We're not the biggest, but we're pretty big. If we can do it, any other plan can do it too. And it's really important for us as psychiatrists and physicians to be able to advocate for our membership and our patients. And the Hippocratic Oath, some people have taken other oaths. Mine was a Hippocratic Oath. We have a paragraph, actually a short sentence, that talks about taking care of our patients. And I had a mentor back when I was a freshman medical student that helped me understand that our patients are not just the patient sitting across from us, but our patients are the people in our community, in our state, in our region, in our country, and in the world. That's our obligation. So if we can change processes and make them effective, then we have done our work as best we possibly can as physicians and as treating providers. It's not just doctors, it's treating providers. It's all a team. We're all working together to try to make this better.
If anybody who's still on the call wants to ask their question, there's several that can be a little bit lengthy. One of the comments I want to be sure you all hear is that Deborah Morrison, who's with the AIMS Center, had to jump off, and she wanted to be sure that we know that AIMS does have a monthly call where you can get questions answered if you're having some in the weeds kind of questions. So just want to make sure that you know that the AIMS Center has office hours, and you can find it on their website, and it'll be in this recording, and we'll share it.
And they've been very helpful. We've been working on developing specialty co-care products or services in the substance use disorder space. There's a nice article about a program called the Summit Study. It was done in finished up in 2018, that looked at using collaborative care processes for substance use disorder. The takeaway was their outcomes were a 35% better relapse prevention than treatment as usual, just because of the model itself in an 18-month to a 1-year program. That's incredible to be able to make those kind of changes in substance use disorder space. And we have a protocol that we put together through COVID that was mentioned, that takes people through outpatient detox, using collaborative care as a mechanism to be able to do the case management, care management, and coordination. We do know that there's a lot of psychiatric need in the substance use disorder population. So, with that, we treat both of the situations, and that we've made the IOP and PHP programming paid for via telemedicine, so we can be able to do that as an outpatient, and then also continue to treat them through community resources, medication reviews, family therapy, really kind of a really holistic way of being able to treat people with substance use disorder. And have had some providers that have taken this on in pieces. And we've also got a major provider in Ann Arbor that's looking at developing an entire protocol following our protocol via telemedicine. So
Do you have a
exciting
sense?
times.
Do you have a sense that that's going to continue to be paid for after COVID is over?
Yes, we will. We will. I'm not sure if other payers will, but we are going to continue moving forward with this.
You mentioned giving incentives to the primary care clinics. How have you recruited psychiatrists, and are there a number of psychiatrists doing it? Are they totally doing collaborative care for several practices, or are they adding pieces of it to their psychiatry practices, traditional psychiatry practices?
Yeah. Many of the provider organizations have psychiatry professionals that are employed physicians, and they've been able to repurpose those physicians' time into the collaborative care support of the practices. That's been where the most of it has come from. We also have I have found a couple groups that have been doing telemedicine services in Michigan for about 20 years. And they contacted me, they have an interest in also providing collaborative care, psychiatric consultation services. And with that, they've become interested in doing this. We've given them some advertising space, if you want to call it that, to introduce the practices to them. And then after that, we step out of it, they cut their own deal, their own contracts and that sort of thing. So we've kind of acted as a catalyst to be able to introduce and be able to find folks to be able to do this, or that have an interest in this, have done the training through the APA and want to do that. We also have an incentive that is run through our HMO, because we have what's called behavioral health incentive program that we pay for $2,500 for a psychiatrist to sign a contract and stay in the practice for at least 60 days, seeing or influencing the care of collaborative care patients. And we've had one taker of that so far, but I'm sure that will pick up. It's going to really pick up in 2021 as this gets rolling.
I'm in Florida and starting a program, sort of like a team care type program, looking at both diabetes and cardiovascular disease when unmet targeted goals for those, and depression and anxiety. So we're doing it with mostly Medicare, but we have some Blue Cross Blue Shield patients as well. But so is the no copay nationwide on that?
No, there are other plans that are doing this. I don't think I'm at liberty to advertise those plans because of the BCBSA rules, but the one in Michigan, we don't have a copay in any of our products, Medicare, BCNA, HMO, or PPO. And that's all I can really speak to. I would urge other plans to move this direction, but I think that's more of a Blue Cross Association discussion item that the plans are going to have to decide to do that.
Mm-hmm. Okay. All right. Thanks.
Sheila, I'm at Mayo Clinic, and we did do a version of team care we called Compass here over the course of a year or so. And there are some challenges with that model that are a little different than the regular collaborative care. One thing we were able to do with at Mayo is we were to argue that the copay cost, if it was prohibitive for patients, might be something the institution would help step up for, because their losses in ED and hospital visits were so much higher than if they could help cover the copay. So some patients could pay for it, but those that couldn't, we'd try to use institutional support for, which isn't the best long-term solution, obviously, but you might consider that if that's possible with your institution.
Yeah, one other consideration is the provider-delivered case management codes are payable nationally. Whether local plans pay for them is a different story. But that is similar to co-care, except no psychiatry consult. And with that, it is considered a prevention service. So with that, you don't have a copay that goes along with the PDCM codes. Again, it's very specific to the plan that you're covering and in the geographic area that you're at. Our PPO product, our commercial product, does have PDCM also. So we have both collaborative care and provider delivered case management. Little different models, but similar in that regard.
Other questions that we can go to? We have a long list from the chat box, but I just want to see if anyone feels comfortable raising one in person.
And Dr. Williams, if you could speak either closer to your mic or a little louder, that would
I'm
help us
sorry.
all.
Let's see if I can turn it up.
This is Kelly Mafia. I don't know if this is an in the weeds question or not, but it seems appropriate. One of my questions in the chat box was just any recommendations about how we should be documenting the psychiatric collaborative care between PCPs and the psychiatrist in order to support reimbursement for those codes.
I can tell you what my spin on that is. The folks from the AIMS Center may be able to help answer that question more detailed. But in general, it comes down to the behavioral health case manager really is in a role that needs to be documenting the time and also the interactions. The psychiatrist, the consulting psychiatrist, can be a part of that. They can decide how they want to share that responsibility as far as the documentation and the record. But ultimately, I think the coordination comes down to the behavioral health case manager. That's where you're going to have the integration of the message getting to the primary care doctor through the EMR if you have one, or other records, other mechanisms. But going through each of the cases in the registry on a regular basis, being able to document what's done, I think those are important pieces of that. Dr. Williams, so you've been teaching this. What are your thoughts on how this should be done?
Can you hear me?
I can hear you now.
Better?
Yep.
Okay, sorry about that. I didn't realize that. Appreciate you pointing it out. Yes, so what we encourage, just like Bill said, you need to make sure that your care coordinators are doing the bulk of keeping track of time because it's their time. And when this fee for Medicaid or Medicare was first figured out, it was thought to include the psychiatrist time and a little bit of the primary care provider's time in the overall money that's paid. Of course, things get changed over time and discounts, et cetera. But so what we encourage the psychiatrist to do is to document that they reviewed patients in some way, and then think about clinically how you're going to tee up the primary care provider to actually know what to do, because that's what you're doing. You're supporting them to deliver these care. So document it for that purpose. So our actual, we do kind of standardized notes here at Mayo, and that's kind of what we're doing in the teaching as well, that the psychiatry documents on all the patients in the chart, but does it in a very targeted way about assessment and plan, not reviewing all of the past information. And there's sort of a different week by week, at least what we do here and what we were talking about in the training. You have patients who are new, who don't have any plan yet, so you have to document a little more because you have to suggest a direction for that patient. Then you have patients who are really, it's too early to do much for them. You reviewed them last week. And so you just touch on them, run the list, so to speak, and write something only if you need to recommend something. And then you have we suggest once, we've been doing care coordination since 2008. We suggest a once a month note on everyone where psychiatrist writes something in the record, because what happens otherwise is that, the noisy patient gets the attention and other people fall through the cracks. So that's aiming at getting fidelity to the model and outcomes as much as it is towards some billing person looking over to see if the things are all written. I think the main thing from the billing side is to show that the psychiatrist actually did review cases and it wasn't theoretical that there was a review.
And this is Diane from the AIM Center, and I just, you know, reiterate what Drs. Beecroft and Williams pointed out. You know, from a billing perspective, it is the care manager's time that's being counted in terms of the CMS codes, and so they need to document all the activities they're doing, including the consultation that they're doing, the psychiatric case review with the psychiatric consultant, in terms of how the psychiatrists work as part of the collaborative care program is being documented. Each organization, you know, comes up with how they want to do that documentation. And I think what Dr. Williams was pointing out is, you know, a nice way to do that. But each organization, you know, will figure out how they want that documented in their EHR.
And I think it's very dependent on the EHR system that the institutions use, because they have limitations and you have to fit it within their formats.
Exactly. It's been challenging when we've taught this over the years that some organizations actually contracting with psychiatry doesn't have direct access to the EHR or can't see the notes the same way. And so, and then people are worried about liability, so they don't want to put a note in the record and that kind of thing. My own experience is that if by putting a note in the record, my colleagues get to know me and actually learn something, so that hopefully, and so that then when they have a patient similar to the one I'm documenting, they might actually be able to do things without contacting me. And so I see it as a teaching opportunity, and so that's the way we've gone. But like Diana said, I've been involved in teaching about this, and I found that every organization has its culture, and you have to respect that.
And I've actually been actively involved in teaching the PCPs, even
Good.
you know before we got involved in the co-care model, which is we're just starting.
That's great. Good for you. It's fun to work with primary care providers, at least for me, I think. I hope the rest of you see it the same way.
You know, a lot of the ones that I work with are very afraid to prescribe anything other than benzodiazepines and 1 or 2 different antidepressants.
Yeah, interesting. Yeah, no, what has happened since like I said, we've had care coordination since 2008 going. The people that, you know, there's a lot of turnover in primary care, so there's always somebody new. But the people who've been around a while, now they're sending me, I know I've tried the person on 3 different medicines. I've augmented with a Boost Bar and Abilify, and they're not really better. What do you think? I'm like, holy smokes. So they learn and they get more and more sophisticated.
Right.
So. Oh, Karen, I think you're on mute.
Okay. I just have a question of clarification again. So I mean, I'm always embarrassed to say this because we've been doing this for 2 years and we have not billed, and it just has to do with just trying to get this hospital to do this. But I mean, because we've been all set up to do it on our end, the behavioral medicine end. But anyway, like when you're doing a note, like a note, we do case conference notes when we meet on the patient. Would you then document like how much time you spent talking about that person, like in the note? Is that what you do in your electronic medical record? Like, would it say, you know, 12:40 to 12, you know, to 1 o'clock, or would it say 15 minutes or 20 minutes or whatever? How does that work? I just wondered. Sorry, I mean, that's a really basic question, but
yeah, I guess because the care coordinator or care manager is keeping the most track of time in order to bill, then the onus is a little harder on them to be tracking this. We have, and Anna Resliff and I wrote a little paper on how to do these SCRs that's in, I think, Psych Services with a couple other people. We have kept track of the time more out of efficiency than out of billing, because what can happen is, you know how it is. You can have a patient that's really kind of, you admire the problem for a good half hour or an hour, and then you have, all these patients to go through. If you try to keep your caseload for your care manager, care coordinator up a little higher, you have a lot to go over in 2 hours if they have a full caseload. So some of the timekeeping has been more around that issue, You could use it, I guess, if you're worried about getting audited, to show that the time that he or she put down for the review with the psychiatrist is covered somewhere. So I don't think it hurt, but I'm not sure that as a psychiatrist you necessarily need to do that. The other thing, though, just another aspect of this in a big institution, is the psychiatric practices are all often fee for service, right? So other parts of my department, they look at whether we as psychiatrists are doing our job by how many patients we saw for how much time, and billing and RVU type things. So when you work in an institution like that and you're trying to prove to your administrator that you're not just sitting around, how do you show them that you're doing the time, that you're doing something, right? Because if you're just supporting care managers. So in those situations, you might need it for that purpose, to show that, a typical new patient takes X amount of time, a typical follow-up takes X amount of time. But strictly for billing, I think only if it supports the care manager, care coordinator, unless someone else has a different view. That's how I would think of it.
Thanks.
Yeah, because you can't really double book,
Sure. Yeah.
if you're talking to the care manager and you can't be billing for the same 10-minute period of time.
Right.
So the care manager really is the keeper of the time clock on those cases, and should be able to keep it into an Excel record, or there's a variety of different time and billing software programs and apps that you can put on your iPhone that are available on the internet, not specifically for this purpose, but can do the same sort of thing of keeping track of time on that patient.
I just wanted to jump in. This is Sarah Harmon. I'm a consultant psychiatrist for a program in Pennsylvania, New Jersey, New Jersey. And what we do in our program is, as the psychiatrist, the behavioral health care manager tracks all of the other time, but I track the discussions we have together, because I include in that time the time I spend communicating directly with the PCP, which often happens like when we discuss a new patient, I put a note in the chart, but sometimes there's additional information that I want to share privately with the PCP, like that doesn't necessarily go in the chart. Or something I'm not sure about or whatever. So I track that time separately, and we don't duplicate it, because we just have a very clear division that the only thing that I track time for is those discussions, and any other time I put in on those patients related to the discussions.
Yeah, that sounds pretty efficient. Sounds good.
Dr. Beecroft, do your policies designate specific disorders for medical necessity of the collaborative care management codes?
We have not, and I have purposely had them configured that way, looking for the future. We know currently the big focus is on depression and anxiety, and that's fine and good. It's going to get us a good start, gets practices up and running. But my vision is that this could be used for much more severe mental illnesses as the practices mature. There's no reason that a person with schizophrenia, except for possibly the severely symptomatic schizophrenic patient, schizoaffective disorder patient, couldn't be managed in a primary care office with a psychiatric practitioner working with them to be able to keep them on track. I'm not saying that they have to deal with the acute exacerbation, but once they're through a hospitalization, stabilized on a stable protocol, the minor acute exacerbations can be, I think, taken care of in a primary care setting with that kind of depth and those kind of resources, especially as the practice team develops a sense of reliance on each other and respect for each other's boundaries. Also knowing when to say when, and be able to have the referral to an inpatient or a higher level of care as they need to. And that's what we're trying to develop, is the other foot dropping here in Blue Cross of Michigan, is the continuum of care. We want to be able to have, just like medicine, urgent care, we have them. Observation, we have them. Crisis residential programs, we have them. And programs on the other end of the hospitalization level of care of chronic case management, we have that. Do we have it all over the state? No. Are we building it? Yes. But we're moving in that sense of having that continuum of care, not only for the parity issue, but for the quality, that it's not just the knee-jerk reaction, patient goes to the ER, goes to the hospital. We know that only about 40% of people need to be in the hospital when they go to an ER for a behavioral health condition. That means 60% could go to partial hospital, crisis res, mobile crisis programming, outpatient services, med reviews, something else that would be able to suit their needs and not expose them to the dangerousness of a hospital. And what I mean by that is there's stigma that goes along with hospitalizations that last for the rest of these individuals' lives. There's exposure to other risks in hospitals themselves. Hospitals in general are a dangerous place. There's bugs there, not just COVID bug, but there's other things that they can get in trouble with. So the issue is looking at being able to provide all of those services for our patients. And it's a work in progress. It's going to take me the rest of my career to pull this together. And I'll need a lot of help from a lot of people. It's not just me. But I think that that's something that we're trying to do. But that's why I'm thinking that this can be a component of pretty significant behavioral health product and way of being able to practice that engenders the assistance from our primary care specialists that can help us in this space. We're helping them because right now they get 85% of the duty with behavioral health cases. If we step in and can help them to be able to treat these folks, then they're helping us on the other side be able to take care of the patient load that we as providers can't do either because there's not enough of us. So it's kind of a win for everybody here again.
I appreciate your comments and all the questions so far. It's right 12:58, but I just wanted to see if there's anybody that has any questions they've been holding back or wanted to say anything. I'll be on here for a few more minutes, but I want to respect your time.
Yeah, I've got a 2 o'clock, so I got to go. But one more question.
You are getting a lot of thanks. People are appreciating what you're doing and of sharing this with us. So appreciate your time, and hopefully this will be a continued conversation. So
Sure.
this will be recorded. We'll be posting it on the Collaborative Family Healthcare Association Psychiatric SIG website, and I will have it. So if you need it, and then we can continue to have further conversation. If you would like the Psych SIG team to arrange another type of training like this, let us know if you have any specific speakers or interests, and we'll make that happen.
Yeah, and thank you for your time. Hopefully this has given you some sense of lighting the fire for yourself, that you may be able to do some of the same things, and you've got support of the rest of the team here. We can all be working together on this to be able to help our patients get better.
Thanks so much, Bill. That's amazing work you're doing. Really appreciate it.
Yes, it is.
Thank you. Bye now.
Thanks, everyone.
Yes, thank you very much. Bye.
Bye.